Okay, so we will continue with our discussion of infections, and here we will cover a little bit about bacterial pneumonias, atypical pneumonias, but most of our time we'll be discussing tuberculosis and atypical mycobacterial infections. So if I tell you that this patient has a fever and cough, we look at the PA and lateral chest radiograph, we notice a hazy opacity here that slightly obscures the left heart border, and then here it is on the lateral view. So what is the most likely cause? Well, this is pneumonia, most likely community-acquired pneumonia, and those are usually streptococcal pneumonia. So streptococcal pneumonia is the most common community-acquired bacterial pneumonia, and a lobar consolidation is a typical appearance. Here's another example where we have consolidation now within the right middle lobe. So the bacteria are inhaled into the periphery of the lobe, and the exudate spreads via interalveolar connections rather than through the bronchial tree, which is why it tends to stay localized as a confluent consolidation within a particular lobe. And if we show you this case and say this is pneumonia, so we have an extensive right upper lobe pneumonia here, but what is peculiar about it is that there is bulging in the fissure, especially here along the major fissure. So this is called Friedlander's pneumonia, typically associated with Klebsiella, although other gram-negative organisms can also do it. And we get expansion of the lobe here because of a voluminous consolidation, a voluminous inflammatory consolidation that causes bulging of the fissures. And this can be associated with complications like abscesses, cavities, and empyema. Now, if we look at this radiograph, here we have multifocal opacities here spread throughout the chest, and again we'll say that this patient has pneumonia. In this case now we're talking about bronchopneumonia because we have multifocal consolidation that is most likely spread through the airways, and the typical organism for that is staphylococcal pneumonia, which can be secondary to aspiration. So staph is the classic organism for bronchopneumonia, and here it spreads via the bronchoepithelium, the bronchiolar epithelium, to produce multifocal, these ill-defined consolidations. Now, if I tell you that this patient has acute onset of fever and cough, and we see here some ground glass opacity and some interstitial changes here predominantly in the upper lobes, well, this is an example of an atypical pneumonia. So for atypical pneumonia, we think of viral pneumonias, but we can also think about pneumocystis, especially if the patient is HIV positive, and that was the case here. So atypical pneumonias we can see with pneumocystis, viral, mycoplasma, and these give you an acute interstitial pattern of opacities on the chest radiograph. So Mycoplasma pneumonia is the most common non-bacterial pneumonia here. Of course, we're leaving COVID out of the discussion here. And here we can get an interstitial pattern as the classic pattern of this particular atypical pneumonia. Other types of unusual pneumonias, Legionella pneumonia. So this is can give patients a severe pneumonia. Many times the patients have some predisposing chronic diseases. The Legionella is an aerobic gram-negative bacillus that can be found in aquatic environments like reservoirs and humidifiers, and this can give patients a severe pneumonia with high fevers. And the consolidations are somewhat nonspecific, so you can have patchy consolidations as we see here. Pleural effusions may also occur. And here's another example where we have multifocal consolidations. We see some cavitation in this particular case, but cavitation is unusual with this particular infection. And it usually takes a while to clear as the resolution can be slow and lags behind the clinical improvement. Another example of Legionella pneumonia here, extensive consolidation here in the right lung, which we can also see on the CT scan. Okay, so here in our next case, we have this chest radiograph that shows us a right pleural effusion, but in addition, there is increased right paratracheal opacity and also increased opacity here in the right hilum. So this patient has a right effusion with right paratracheal and right hilar lymphadenopathy. Now, of course, this could be neoplasm like lung cancer or lymphoma or metastatic disease, but if we're talking about infections, the infection to consider here is tuberculosis. Tuberculosis can present with lymphadenopathy. So the tuberculosis has been increasing the incidence of this because of immunosuppression with AIDS and also because of immigrants from endemic areas. And populations at increased risk for tuberculosis include HIV and AIDS or any immunosuppression, diabetics, patients with underlying lung disease, patients with underlying malignancy, elderly patients, immigrants from endemic areas, and interestingly, post-gastrectomy patients are also at increased risk for tuberculosis. Now, in terms of the terms you need to be familiar with, you need to be familiar with these terms: primary tuberculosis, progressive primary tuberculosis, reactivation, post-primary or secondary tuberculosis. All of those mean the same thing. And then, of course, miliary tuberculosis. Now, with exposure to tuberculosis, in 70% of cases, nothing happens. In 30% of cases, patients go on to develop a primary infection here, and in a small percent that can progress to progressive primary infection. But in most patients, that infection is contained, and in the vast majority of these patients, we get continued containment. And in a small percentage, these patients can get reactivation of disease later in life. So the vast majority of patients who are exposed to tuberculosis really do not develop any significant sequela from that exposure to tuberculosis, except that they may have a positive PPD as immunologic memory because of the exposure. So with exposure to tuberculosis, patients can develop a localized pneumonitis, and the organisms can survive despite phagocytosis by macrophages. So the mycobacteria are carried to lymph nodes via the lymphatics, and they can be deposited all over the body within lymph nodes, kidneys, epiphyses of long bones, lungs, vertebral bodies, brain cortex, which is why many years later patients may develop foci of active tuberculosis anywhere in the body from this hematogenous dissemination at the time of first infection. So the severity of disease is related to the strength of the immune response. If cell-mediated immunity is strong and competent, the original focus and the disseminated foci of disease are eradicated, the patient will have enhanced memory for TB antigens, hence positive PPD. If cell-mediated immunity is less vigorous, the disseminated disease can be walled off, although it may still remain viable, and so reactivation becomes a risk later in life if cell-mediated immunity becomes impaired. The destruction of tissue from reactivation TB is due to a hypersensitivity reaction to the antigens of the organism, so it's the immune system that causes the tissue destruction, not the organism itself. If cell-mediated immunity is impaired, after initial infection, patients may develop progressive primary TB, and if there is a very limited immunity, patients may develop hematogenous dissemination of active disease, and that's where we can have miliary tuberculosis. Now, the traditional teaching on TB was that in terms of the radiographic appearance of primary versus reactivation tuberculosis, that there was a difference, that primary tuberculosis can't present as consolidation, effusion, or lymphadenopathy, and that it was reactivation of tuberculosis that presented as upper lobe fibrocavitary disease. Well, it turns out that that traditional teaching is not quite right, and that particular article outlines it very nicely. So let's define some terms. Primary tuberculosis is disease within 1 year of infection. Reactivation tuberculosis is activation of old previously latent infection greater than 1 year since initial exposure. And the way we can differentiate between these types of infection is through DNA fingerprinting of tuberculosis strains. If there are genetically identical strains of TB affecting more than one patient, then we have a cluster, and so then we can assume that that is primary infection. However, if it is a unique strain of tuberculosis affecting only one patient, then that is most likely reactivation tuberculosis. So it turns out that the radiographic appearance of tuberculosis does not depend on the time since infection, but on the immune status of the patient. So we see upper lobe cavitary disease in immunocompetent patients. We will see lower zone disease with adenopathy and effusion in immunocompromised patients. So there is no difference in the radiographic appearance between true primary tuberculosis and true reactivation tuberculosis. What we see on the radiograph depends on the immune status of the patient, regardless of when the patient was infected. So the immunocompromised host will show us lymphadenopathy. The immunocompetent host will show us upper lobe fibrocavitary disease. So the three predominant radiologic findings that we might find in the immunocompromised host in any combination, we might see consolidations, adenopathy, pleural effusions, any of those three, any combination of those three. The consolidations may be patchy or lobar. They might occur in any lobe. They're usually chronic, they may not cavitate, and they will require weeks or months to clear, which is why if a patient is being treated even adequately, we don't get chest x-rays every week like we do with bacterial pneumonias. Here the x-rays will be spaced months apart because it takes quite a while for these opacities to clear. Consolidations in children can be due to obstructive atelectasis from enlarged lymph nodes, and consolidations are more common in older children and adults compared to children less than 3 years of age. So here you can see an example, consolidation here in the right upper lobe from tuberculosis. 1 month later, the x-ray looks exactly the same, even if the patient is being adequately treated. We might see adenopathy also in immunocompromised hosts. So these nodes can be hilar or mediastinal, most commonly right paratracheal, right hilar, or subcarinal lymph nodes. So here on the old x-ray, we see a normal right paraspinal line. On the new film, we see the thickening of the right paraspinal line representing right paratracheal lymphadenopathy, which is confirmed here on the CT. So prevalence of adenopathy decreases with age, so it ranges from 90% in the pediatric age groups to 10% in patients greater than 50 years of age. Now, what can be characteristic of lymphadenopathy from tuberculosis is this low attenuation lymphadenopathy with peripheral enhancement, as we see here with infiltration of the fat planes around the mediastinum. So this can be a characteristic appearance for CT lymphadenopathy, central low attenuation with enhancing rim. So if we see this appearance in lymph nodes, we can consider tuberculosis. Other things that can be in the differential diagnosis are necrotic nodes, lymph nodes from metastatic disease from squamous cell cancer, and occasionally seminoma might also give you low attenuation lymph nodes like that. Now this patient has this calcification that we see here in the right lung along with these calcified lymph nodes, and there is a term for this when we see this complication or this combination of findings. So that term is a Reinke complex. The Ghone focus is the initial site of parenchymal involvement that can heal with or granuloma, calcified granuloma, as we see here. The Reinke complex is when we have the Ghone complex plus an abnormality within a lymph node, either an enlarged or a calcified lymph node. So the combination of a calcified granuloma and calcified lymph node is called a Reinke complex. Pleural effusions can also be seen in the immunocompromised hosts. This probably results from a hypersensitivity response to the tuberculoprotein, which is released in the pleural space. Can be unilateral and usually unilateral, but it might be bilateral, and it usually occurs on the same side as the parenchymal disease. So the prevalence of pleural effusion increases with age. so 10% in children to 35% in adults. And pleural effusion may be the only finding in 5% of adult cases with tuberculosis. So in a patient with a large pleural effusion, it might be the only finding. We need to think about tuberculosis, especially in a young patient, in our differential diagnosis. Now, progressive primary TB is if in the patients who are initially infected, the cell-mediated immunity is inadequate to control the primary infection, and these patients go on to develop chronic active disease. So they develop this chronic active tuberculosis within 1 year of initial infection, and this can affect young people, and these patients can have upper lobe fibrocavitary disease. So what is the differential diagnosis when we have upper lobe fibrocavitary disease? Like this, well, certainly tuberculosis is the first thing to consider. Sarcoid can also give you upper lobe fibrotic disease, like we see here. Other things to think of in the differential diagnosis: atypical mycobacterial infection, which we will cover later, and also the semi-invasive form of aspergillosis might also give you upper lobe disease that can resemble tuberculosis. So for reactivation TB, the risk of reactivation is greatest within the first 2 years after primary infection. The factors that predispose to reactivation, certainly age, immunosuppression, underlying diseases as listed here, and underlying lung diseases can also increase the risk for reactivation. So the findings that can be associated with tuberculosis, we can have upper lobe consolidations, cavities, fibrosis, bronchiectasis, bronchogenic dissemination, tuberculomas, pleural disease, and dystrophic calcifications. So the parenchymal changes of tuberculosis occur predominantly in the apical and posterior segments of the upper lobes and the superior segments of the lower lobes. Older theories explaining this said that this was because of increased oxygen tension within these regions that promote growth of TB. More recently, we've come to believe that this is because of less efficient lymphatic drainage from these regions, resulting in accumulation of TB antigen within these regions of the lung. So with tuberculosis, we can see these chronic patchy upper lung consolidations that commonly cavitate, as we see in this example. And whenever we see an appearance like this on a chest radiograph, if this is the first time we're seeing the patient, we want to put the patient in isolation, especially until the diagnosis is confirmed and adequate treatment is started for the patient. So we can see fibronodular changes within the upper lobes with fibrosis, with volume loss, retraction of hyla. You can see the right hilum here is retracted superiorly, dystrophic calcifications, and bronchiectasis. So many of these reticular opacities that we see here, especially if they're tubular, represent bronchiectasis from scarring within the upper lobes. Now in this case, we have a patient who has a large cavitary lesion here from tuberculosis, but in addition, we see these nodular opacities bilaterally. Now you might be thinking miliary disease, but these nodules are a little bit too large for miliary disease. So what is going on here? This is bronchogenic dissemination of tuberculosis. So bronchogenic spread of tuberculosis can occur when a cavity erodes into an airway, resulting in spread of the organism through the tracheobronchial tree, and then we develop these small nodules, these so-called acinar nodules, which are larger than miliary nodules. So this represents bronchogenic dissemination of the disease, and we're looking at inflammation here surrounding the airways throughout the lungs. And this can be manifested as a tree and bud pattern also on CT. So this tree and bud pattern here represents bronchiolitis, commonly seen with tuberculosis, and again indicates bronchogenic dissemination of disease. And here's a nice example where we have a cavitary lesion, and adjacent to it we have tree and bud opacities. Cavitary lesion, tree and bud opacities adjacent to that. So this represents bronchogenic dissemination of the tuberculosis. So tree and bud is an indication of infectious bronchiolitis, And although any organism can do it, we certainly need to consider tuberculosis in our differential diagnosis. If I tell you this patient has a history of TB and has these nodular dense opacities, what are these called? There's a term for this. These are called tuberculomas. These are tumor-like foci of TB within the lung parenchyma. They're usually oval or round. Margins may be regular or irregular. And these can have viable organisms. They represent a fine balance between activity and repair. So they can also calcify, as you see here. They can be multiple, and these may grow slowly. Now we can see apical pleural thickening also associated with tuberculosis. It's common even after appropriate therapy, and this can be associated with scarring. What happens is with the volume loss, sometimes what we see as this apical pleural thickening really represents the apical fat, the subpleural fat, that comes down into the area filling the space where the lung has been withdrawn because of scarring. So if we see this appearance, then this apical fat in this region, we know that this is filling in the space from volume loss in the right upper lobe from scarring. Okay, in this example, we notice that the heart is shifted to the left. There is volume loss here in the left hemithorax. We also notice extensive calcification here of the pleura throughout the left lung. So there is a term for this. This is called fibrothorax. So severe pleural thickening and pleural scarring from tuberculosis can result in fibrothorax. And if we look here on CT, we can see this extensive pleural calcification here around some organizing collection. So there is a differential for pleural calcification. We can see pleural calcification with tuberculosis. We can see it with asbestos-related pleural disease. We can see it with chronic empyemas, either from tuberculosis or other organisms. So these are considerations for pleural calcifications. Occasionally, talc pleurodesis can also give you high attenuation within the pleural space, but that looks much more powdery, that has a somewhat, or granular, that has a somewhat different appearance than this. This was a case of chronic TB empyema with pleural calcification. So pleural disease can occur from tuberculosis. We can get effusions, we can get loculated fluid, you can have empyemas. If a bronchopleural fistula forms, you can get an air fluid level within the effusion. The effusion may remain stable for years and may persist even with calcification, and it can contain viable organisms. So you can have chronic empyemas from tuberculosis, as in the example that we saw earlier. Now, miliary TB is when the host defense mechanisms are overwhelmed and there is hematogenous dissemination of tuberculosis. This can occur with primary or reactivation infection. Initially, the radiographs may be normal early in disease, and we may not see the changes until a few weeks after hematogenous dissemination occurs. But the hallmark are these small, tiny nodular opacities scattered throughout the lungs for miliary tuberculosis. So this miliary pattern, this micronodular or reticular nodular pattern we might see with miliary tuberculosis. There might be other findings that suggest TB, like consolidations, cavitations, calcified nodes, or adenopathy, but occasionally there may be no other findings to suggest TB except this miliary appearance. This gives you a random distribution of nodules because it is hematogenous dissemination, and that is the distribution of nodules that we will see on CT with miliary tuberculosis. If I tell you this patient is PPD positive and we ask for your assessment of activity of disease, what do you say? Well, the finding here is that there is a calcified granuloma. So how do we assess the activity of disease in this case? Well, a normal chest x-ray has a high negative predictive value for active TB in the immunocompetent host. There's only a 1% false negative rate, but you have to be careful in HIV positive patients. They can have a higher false negative rates. But a single screening chest radiograph with any abnormality, whether it's parenchymal, nodal, or pleural, with or without calcifications must be interpreted as indeterminate for activity of tuberculosis. So if there is an abnormality that can be related to tuberculosis, if we don't have prior chest radiographs for comparison, then that radiograph is really indeterminate. So here's an example where we have a patient with active tuberculosis who is treated. After therapy comes back, there are still some residual changes here in the upper lobes with retraction of the hyla. If you have both x-rays, then you can say that this patient is certainly responding to therapy and the radiograph looks better. However, if you don't have both x-rays, then what we have here we would have to interpret as indeterminate for active tuberculosis. Now, if we have prior radiographs and the radiographs remain stable for 6 months, that usually indicates an active disease, and we can interpret that as radiographically stable disease. So the phrase to use there is radiographically stable. Now, TB foci can remain inactive over an extended period of time, and they can still contain viable organisms that can lead to reactivation later. So cavitation and miliary disease are definite evidence of active disease on chest radiograph. So we have cavitation here in the right upper lobe. So if we do see cavitation and we believe it's from active TB, you do want to isolate that patient until the patient is adequately treated. Other complications of TB, we can see various parenchymal complications of tuberculosis. We can have these cystic spaces as a result of scarring from tuberculosis. Here there's some parenchymal opacities, and after therapy the parenchymal opacities have improved, although these cystic spaces remain. What complication of tuberculosis is this? There is a term for this when the entire lung is completely destroyed and scarred down. Here you can see that the entire lung is scarred down and you have all of this extrapleural fat here. So this is called autopneumonectomy. When there's complete destruction of a lung from tuberculosis, the term for that is autopneumonectomy. Another complication of TB that can occur, we can get fungus balls that grow within these pre-existing cavities. So Aspergillomas can be a complication of tuberculosis. So here we have an Aspergilloma that is growing within this cavity from tuberculosis. Any disease that causes scarring in the lung, especially the more extensive the scarring, can increase the risk for cancer. So bronchogenic carcinoma can also be a complication as a result of the scarring that occurs within the lung. Airway complications of TB, we can have bronchiectasis, stenosis, and broncholithiasis. So here in the upper lobe you see all of this bronchiectasis from scarring. This is very common from tuberculosis. So traction bronchiectasis, especially here in the upper lobes with architectural distortion and volume loss. You can see the hilum here is pulled upward. So this is very common from tuberculosis. So here's a coronal reconstruction showing you distortion here of the airways and the volume losses. The minor fissure here is pulled up within the right upper lobe from tuberculosis. Stenosis of airways from endobronchial involvement can also occur. Here you see stenosis of the left main bronchus, and here in this volume rendered view we can see that also this patient with a bronchial stricture. What complication of TB is this? Well, here we have these calcifications. These are actually calcified lymph nodes, but we have atelectasis here from obstruction of an airway. So here the lymph node has eroded into an airway, and this is called broncholithiasis. So broncholithiasis occurs when a calcified lymph node here erodes into an airway and then results in obstruction and atelectasis. You can also develop post-obstructive pneumonias. What complication of TB is this? Here we have what looks like a large mass, and on the CT we notice that after contrast there is this large enhancing region here. Well, this is a large pseudoaneurysm from tuberculosis, so this is a Rasmussen aneurysm. There are various vascular complications from TB, pulmonary or bronchial arteritis and thrombosis, bronchial artery dilatation, and Rasmussen aneurysm. So these represent pulmonary artery aneurysms that occur in the wall of a tuberculous cavity, and of course these are at risk for hemoptysis. Bronchial artery dilatation can also occur with tuberculosis. Whenever you get scarring, you can have hypertrophy of the bronchial arteries. So we have these hypertrophied bronchial arteries, and here on the angiogram we can see that too. This can be a source of hemoptysis that can be fatal also if it's not treated. So for this, patients may need to go to embolization if they develop hemoptysis as a complication of bronchial artery dilatation from tuberculosis. So Rasmussen aneurysm is a pulmonary artery aneurysm that occurs within the wall of a tuberculous cavity, and of course these patients are at risk for hemoptysis. Other thoracic complications of TB, we can have mediastinal lesions involving lymph nodes as listed here. So here we have lymph node calcification. You can see after therapy the lymph node gets smaller, although the calcification increases in size. We can have inflammatory erosions from the lymph nodes into the esophagus. So here we have an esophago-mediastinal fistula, and you can also get esophagobronchial fistula. So the lymph node itself can erode into the esophagus or into an airway. So here we see a fistula between the esophagus and the airway as a result of the inflammatory disease in the mediastinum. Now, fibrosing mediastinitis usually is caused by histoplasmosis, but occasionally tuberculosis can also give you fibrosis here within the mediastinum, leading to fibrosing mediastinitis. Another complication of TB illustrated here, we have extensive pericardial calcification. So constrictive pericarditis can be a complication of tuberculosis. And then for pleural lesions, as we've said, we can have chronic empyema, fibrothorax, bronchopleural fistulas, pneumothorax, and the chyliform or pseudochylous pleural effusion is another interesting complication that can occur from tuberculosis. So chronic empyemas, we can have collections here with pleural calcification from tuberculosis. Fibrothorax we've touched upon earlier, where we can have extensive pleural thickening and scarring, leading to volume loss on that side and impaired ventilation. And here we have this large air fluid level in the left pleural space. So this is from a bronchopleural fistula. This can also occur with tuberculosis. And here we can actually visualize this bronchopleural fistula, in this case, opening into the pleural space from tuberculosis in this particular patient. And of course, pneumothorax from tuberculosis infection, especially if the patient has a bronchopleural fistula. This chyliform or pseudochylous pleural effusion is another interesting complication. So what happens here from chronic empyema, these patients develop a high lipid non-chylous effusion because of white blood cells that die within this chronic empyema, and so cholesterol and lipids from those dead white blood cells accumulate, and so you can have this fat fluid level here, and you can also develop milk of calcium here that layers out dependently, and here there's some fat more anteriorly. And then here we have extensive calcification, a little bit of fat layering out anteriorly in this case, and here's milk of calcium layering posteriorly. When you turn the patient prone, you can see that shift to the anterior location. Now, if I tell you this patient has chest pain radiating to the back, and if we compare this x-ray with the prior x-ray, so here is the right heart border. There it was on the prior study, but there is something bulging out here to the right. So there's bulging of the paraspinal line here on the right, and maybe there's a little bit of bulging also on the left side. So we're thinking of something involving the posterior mediastinum in this patient with chest pain. And this, again, as we look at the close-up, we can see the bulging on the right, a little bit of bulging on the left compared to the prior study where there was nothing there in the posterior mediastinum. So here we have bilateral bulging of the paraspinal lines. And This turns out to be discitis and osteomyelitis with paraspinal abscess from tuberculosis. So paraspinal abscess can give you a posterior mediastinal mass and will cause bulging of the paraspinal lines. In this case, the patient had discitis and chronic osteomyelitis and developed a paraspinal abscess as a complication of tuberculosis. Here's another complication of tuberculosis illustrated here when empyema breaks through the chest wall into the subcutaneous soft tissue. This is called empyema necessitans, so that's when empyema breaks through the parietal pleura to form a subcutaneous abscess. And there are some other chest wall complications that we can also see from tuberculosis. So we've talked about empyema necessitans. We've talked about TB spondylitis. Paraspinal abscesses can occur from tuberculosis. Some more unusual complications, so lymphoma, malignancy secondary to the chronic empyema. So now let's move on to discuss these non-tuberculous mycobacterial infections or atypical mycobacterial infections. So what we need to know here is that there is no human-to-human transmission. These organisms are found within the soil and water, and the culprit organism is Mycobacterium canzasi, Mycobacterium avium intracellulare, or MAC complex, combination of these two organisms, and one of the rapid growers here, Mycobacterium fortuitum colonii complex. So criteria for diagnosis, pretty difficult. So this requires cavitation or progressive disease on a chest radiograph and at least 2 positive sputum cultures or evidence of mycobacteria on lung biopsy or positive BAL culture. So there are various types of appearances that these atypical mycobacterial infections can produce. So if I tell you this patient has non-tuberculous mycobacterial infection, what do we call this particular form of infection? Here, this looks like reactivation, or this looks like tuberculosis with upper lobe fibrocavitary disease. And here it is on the CT where we have this disease here, some cavitation, tree and bud opacities, cavitation there in the right upper lobe. This pattern is called classical disease. It's called classical disease because it's the first type described, and usually it's Mycobacterium canzasi and MAC that can do this. So this is the most types of atypical mycobacterial infection in immunocompetent patients have this form. These patients can have insidious cough, hemoptysis, weight loss. Predominantly affects males, elderly males with predisposing underlying lung disease like COPD. That is the most common underlying lung disease associated with this. So the chest radiograph looks similar to reactivation tuberculosis with upper lobe fibronodular opacities and cavitation, and these patients may also have pleural thickening. So with classical disease, they can get bronchogenic dissemination. Adenopathy and pleural effusion are less common. This may progress slowly, and the chest x-ray may be unchanged for years. So this tends to progress slower than tuberculosis, but it looks just like fibrocavitary disease from tuberculosis with upper lobe disease and architectural distortion, scarring, and the hilum being displaced upwards, as in these examples. So on CT, we can see cavities, bronchiectasis, pleural thickening, upper lung zones, and Mycobacterium canzasi does respond to anti-TB medication, although MAC can be resistant and recurrence of disease may occur. If I tell you that this woman has a chronic cough, and we see here this pattern of disease in the right middle lobe, looks like there's some right middle lobe atelectasis there on the lateral view. And then here on the CT, we can see bronchiectasis, especially bronchiectasis here involving the right middle lobe and lingula, a little bit of bronchiectasis elsewhere also. So this particular form is called non-classical disease, usually affects elderly females, hence it has also been called Lady Windermere syndrome. These patients usually do not have predisposing underlying lung disease, but they can present with chronic cough and hemoptysis. So they can have interstitial opacities. The distribution may be random, but what can be characteristic is bronchiectasis, especially involving the right middle lobe and lingula. So if we see that distribution of disease with bronchiectasis involving the right middle lobe and lingula, so this is the hallmark of non-classical disease or Lady Windermere syndrome. So here's another appearance that we can get with atypical mycobacterial infection. Multiple nodules. Of course, the differential is metastatic disease, and this disease, atypical mycobacterial infection, is notorious for simulating metastatic disease and for giving you a false positive PET scan. So even on PET CT, these lesions can be very active, again, mimicking neoplasm. So atypical mycobacteria can do this. So asymptomatic nodules can be another manifestation of atypical mycobacterial infection. So multiple nodules here from atypical mycobacterial infection. So they may cluster sometimes. Differential diagnosis, of course, is metastatic disease, although with metastases, nodules are usually randomly distributed. They tend to be round. With lung cancer, the nodules tend to be satellite nodules around a dominant lesion. So if I ask you what atypical mycobacterial infection is associated with the findings that we have here, so we notice that there's this large mass extending all the way down. It contains an air fluid level, and here it is on the lateral view extending all the way down, pushing the trachea anteriorly, containing an air fluid level. Well, this is a patient with achalasia. So what atypical mycobacterial infection can be associated with achalasia, as we see the dilated esophagus full of fluid and debris in this particular patient, and here it is on the barium study and also on this coronal CT scan. Well, this is the Mycobacterium fortuitum or colonii complex, or the rapid growers. So what happens here is that the organisms can grow within the dilated esophagus, and then of course the patient is at risk for aspiration because of the achalasia, and the organism gets into the lungs. So this can give you lung disease here from atypical mycobacterial infection associated with achalasia. And these tend to be the rapid growers, Mycobacterium fortuitum, colonii complex. Patients who are HIV positive can also develop infection with atypical mycobacterial disease, and that can present as adenopathy, as in this patient we have right paratracheal adenopathy. Here, of course, the differential is neoplasms like lymphoma and Kaposi's. So this patient has right paratracheal and mediastinal lymphadenopathy, and also lymphadenopathy there within the abdomen. So disseminated disease with atypical mycobacterial infection can occur in patients with AIDS. It's usually MAC. The portal of entry is the GI tract. These patients can be relatively asymptomatic, although they will have positive blood cultures. So they can have paratracheal and hilar lymphadenopathy, mediastinal lymphadenopathy, as we see here on the CT. They usually don't get much in the way of parenchymal lung disease. Sometimes, though, the lymph nodes can be low attenuation, like we've seen with tuberculosis, but atypical mycobacterial infection in patients who are HIV positive can also give you this appearance of low attenuation lymph nodes with peripheral enhancement. They can also get lymphadenopathy within the abdomen, retroperitoneal lymph nodes, and adenopathy elsewhere besides the chest, in patients who are HIV positive who get infection with atypical mycobacterial organisms. If I tell you this patient is short of breath and has this appearance, these kind of patchy centrolobular regions of ground glass opacity, some mixed attenuation here, more lucent areas, and we can see on the expiratory CT there's extensive air trapping. So this is a pattern, of course, of hypersensitivity pneumonitis, but how can this be associated with atypical mycobacterial infections? Well, this is the so-called hot tub lung, where these patients develop these ground glass opacities, these centrolobular ground glass opacities representing a hypersensitivity pneumonitis reaction to these inhaled organisms that grow within the water within the hot tub, and the aerosolized jets allow the organism to penetrate into the lung tissue. It's usually inhaled MAC, and so these patients can develop a hypersensitivity pneumonitis-like reaction. So in terms of Non-tuberculous mycobacterial disease, these are the types of appearances to be familiar with as the classic form of infection, which we see usually in elderly males with COPD that looks like tuberculosis, upper lobe fibrocavitary disease. Non-classical disease seen in elderly women, Lady Windermere syndrome, that is characterized by right middle lobe and lingular bronchiectasis. Patients may also have asymptomatic nodules. Patients with AIDS can develop disseminated infection. With achalasia, patients can also get infection. Those are the rapid growers that can do that, the Mycobacteria fortuitum, Chelonia fortuitum complex there. And hypersensitivity pneumonitis, so-called hot tub lung, that is another type of syndrome that can be associated with atypical mycobacterial infection. So that concludes our session for today. Thank you for your attention, and we'll see you next time.